Assalamu alaikum, everyone. Welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host for today, Mohammad Salameh, and I'm joined by the amazing Omar Al-Saddique to guide us through fibromyalgia and the systemic presentations of musculoskeletal disease.
Hey Mohammed, I'm excited to be here. This topic is one of those sneaky ones in medicine. Patients come in with pain everywhere, fatigue, and weird symptoms that don't fit into just one category. But there are always some keywords that point us in the right direction.
And today's episode will give you all the right clues. Today, we'll walk through fibromyalgia first, what it actually is, why the pain behaves the way it does, and how to diagnose it without overthinking. Then, we'll explore how systemic diseases like rheumatoid arthritis, lupus, scleroderma, spondyloarthropathies, and even non rheumatic conditions like diabetes and sickle cell disease can show up as musculoskeletal pain.
So, we're just solving some mystery cases. Sounds pretty exciting.
Yup. Put on your detective hat, Omar. We've got cases lined up, questions to test you, and a few mnemonics to make your life easier. Let's jump right in.
Okay, so for our first case, we have Sarah, a 34-year-old complaining of pain everywhere for almost a year. She's exhausted, sleeps terribly, and says her brain feels foggy. Her physical examination shows no swelling and her labs are all normal. And she says she's scared the doctor might think it's all in her head. What do you think is her diagnosis?
Sounds like a classic case of fibromyalgia. It's the most common cause of chronic, widespread musculoskeletal pain. And here's the key: the pain has to be in multiple regions for at least 3 months without any inflammatory signs like warmth or swelling.
Think of fibromyalgia as the body's pain processing system, playing the radio too loud. The nerves and brain are amplifying pain signals.
Okay, Omar, explain what's going on behind the scenes in super simple terms.
All right, imagine your body has a pain volume knob. In fibromyalgia, the knob is accidentally turned up, way up. This is called central sensitization, meaning the central nervous system is super sensitive. So even normal sensory inputs become painful.
So the muscles aren't inflamed, the joints aren't destroyed, but the brain is interpreting everything as pain?
Exactly. And triggers like stress, trauma, infections, or even genetics can push the nervous system into this hypersensitive state.
So, how do doctors know it's fibromyalgia and not something else?
To reiterate, first, widespread pain for at least 3 months. Second, fatigue, non restorative sleep, and cognitive fog. Third, normal labs, ASR, CRP, CBC, all normal. And most importantly, so I really want you to autofocus here, no joint swelling or erythema.
So, what's the treatment? Magic painkillers?
I wish. The key is multimodal management. We recommend exercise, especially aerobic and gentle resistance, as well as improving sleep hygiene. We also use cognitive behavioral therapy and some medications like duloxetine and pregabalin if needed. Keep in mind that NSAIDs and opioids don't really work because this isn't inflammation.
Now that we have a good grip on fibromyalgia, let's take our first question. What lab abnormality would you expect in fibromyalgia?
I see what you did there. This is a trick question. Labs are normal. Always remember that.
I fully expected you to fall for it.
Before we move on to our next case, give me a quick little mnemonic to solidify the information in my head.
Sure thing. Conveniently, my mnemonic is within the name. There is no way you could possibly forget it. Think with me. Fibromyalgia. Fibro. F for fatigue. I for insomnia or irritable bowel syndrome. B, brain fog, which means cognitive disturbance. R for rigidity, stiffness of joints and muscles. And O for outstanding pain, which means chronic widespread musculoskeletal pain.
Wow, how convenient. Okay, now on to our next case. So, for our next case, a 28-year-old woman presents with a constellation of symptoms, including chronic joint pain, a distinct photosensitive rash, and recurring mouth ulcers. Her daily life is significantly impacted by profound fatigue, which has persisted for several months.
Chronic fatigue, photosensitive rash, and recurring mouth ulcers. This sounds like lupus, the great imitator.
You're absolutely correct. Lupus, or systemic lupus erythematosus, is a systemic autoimmune disease affecting multiple organs. Arthritis is common with SLE but is non erosive, meaning it's painful but does not destroy joints, like rheumatoid arthritis.
So, if you guys recall from our previous episode on arthritis, rheumatoid arthritis destroys the joints while SLE does not. Got it? What about diagnostic clues? How about you give us some?
It's ANA positive, and we always see some specific antibodies like anti double stranded DNA and anti SM.
And how do we manage patients with SLE again?
We give NSAIDs for mild arthritis, hydroxychloroquine for chronic control, and steroids for flares. You've asked me a ton of questions. Now it's my turn to ask. Let's see if you've listened to anything I've said so far.
Go ahead.
What type of arthritis do we see in systemic lupus erythematosus?
Is it non erosive inflammatory arthritis?
You're absolutely correct. Now let's move on to the next one. So, for our third case, a 50-year-old woman presents with a several month history of Raynaud's phenomenon, where her fingers turn white and blue in the cold. On physical exam, she has noticeable tightening and shininess of the skin over her fingers and hands and reports difficulty fully extending her fingers. She also complains of persistent heartburn and difficulty swallowing solid foods. What do you think is her diagnosis?
So you're saying Raynaud's, tightness of skin, heartburn, and difficulty swallowing. Must be scleroderma.
Precisely. Scleroderma is characterized by, first, fibrosis of the skin, which occurs due to excessive collagen deposition, causing the skin to become tight and stiff. And second, involvement of internal organs, which include lungs and GI tract. When diagnosing scleroderma, we look for, first, anti-centromere antibodies in limited disease, and second, anti-SCL70 in diffuse disease.
Sounds easy enough. And for management?
Supportive. Treat Raynaud's with calcium channel blockers and manage organ complications.
Okay, I'm quizzing you this time. Which antibody is associated with diffuse systemic sclerosis?
Anti-SCL70.
Perfect. It's very easy to remember. Diffuse, scleroderma, SCL70. 3 S's. For limited, it's anti-centromere, 2 T's. Pretty neat. Now let's move on.
Okay, so for our final case for today, a 72-year-old woman recently developed a new, persistent temporal headache accompanied by pain in her jaw when she chews, jaw claudication. She also reports blurred vision and significant stiffness and aching pain in her shoulders and hips. What do you think this one is?
Given her age and classic symptoms, this sounds like giant cell arteritis with polymyalgia rheumatica.
Now, this disease is basically an immune-mediated inflammation of large vessels. It presents with a very high ESR, temporal artery tenderness, and PMR symptoms. Also, it has a very dangerous and very permanent complication, which is,
Is it vision loss?
yes, which is why we immediately administer steroids. We don't wait for a biopsy as to not put our patient at risk.
You know the drill. Time for a question to test your attention span. What is the most dangerous complication of GCA?
Vision loss. Always treat fast. Think inflammation of large vessels, vision loss, 2 V's. Aside from all of the diseases we've dove into, many systemic diseases show up as musculoskeletal symptoms. How about you do the explaining now? The stage is all yours.
Gladly, Omar. Inflammatory bowel disease can cause peripheral arthritis. Sickle cell disease can cause bone pain from infarction. Diabetes leads to frozen shoulder and carpal tunnel. On the other hand, sarcoidosis can mimic many rheumatic diseases. We've reached our final question for today, unfortunately, or fortunately for you guys. Are you ready, Omar?
Bring it on.
Which systemic disease is associated with bone infarctions?
Is it sickle cell disease?
Spot on, Omar. To sum up, fibromyalgia is common, mainly a disorder of pain processing with widespread pain, fatigue, and cognitive symptoms, and usually normal labs but no inflammatory signs. Unlike inflammatory arthritis, which presents with erosive arthritis and systemic features of inflammation. Moving on to SLE, which is a non-erosive arthritis and it's always ANA positive. Then we covered scleroderma, which is skin tightening caused by excessive collagen production. And finally, vasculitis. We mentioned that GCA can cause blindness, so treat it urgently.
But don't forget other systemic diseases like IBD, sickle cell disease, diabetes, and sarcoidosis also produce MSK problems. So always think broadly. Clinically, use red flags such as swelling, abnormal labs, organ symptoms to decide who needs urgent care workup. Use the pattern of symptoms, age, sex, distribution of pain, and systemic features to narrow the likely diagnosis.
Wow, Omar, that was a blast. From pain processing disorders like fibromyalgia to full-blown autoimmune diseases.
And the big lesson is musculoskeletal pain isn't always coming from the joints themselves. Sometimes it's the immune system, sometimes the nerves, sometimes it's a systemic disease.
Exactly, Omar. Thanks for joining us on PodBites. We hope this episode helped clear any confusion surrounding fibromyalgia.
Treat yourself to a pear today. You've earned it. See ya. We give NSAIDs for mild مستحيل بطلت تطلع معي.
لا أحد ياكل. سكروا البوكس البدونات. في background noise.
كمان؟ Treat yourself to a pear.
More enthusiastic. Wait, لا خليه يعيدها.
لا, it's good.